Take two. So good evening, everyone. Tonight's the Ask Me Anything May edition. Thank you for submitting your questions ahead of time. And we'll get to them in just a second, let people log on. But rocking a new pair of blue blocking lenses tonight. These are custom made. I've had a pair similar to this in the past, but that company stopped making the type of lenses I want. So I found the frames on Zenny, bought the frames, bought the lenses, popped out the lenses, shipped them off to a company that dipped them in 450 nanometer blocking tint, and then shipped it back to me today, popped them back into my glasses, and now I have my new blue blocking glasses. They're custom made. So maybe I'll do a talk about these in the future, but tonight's night one of trying the new glasses. So thank you everybody for joining. This is the May Ask Me Anything, and right now just rocking the new pair of Apollo lenses is what I'm going to call them for now. So why don't we see what questions we have. So first, there's a question somebody's asking about how can anxiety affect the heart. So 80% of doctor's visits, not just cardiologist visits, is due to either acute or chronic stress. Anxiety is just one of those types. But anxiety, will raise your cortisol, adrenaline. All your stress hormones are elevated. When you have high stress hormones, that causes at times palpitations, heart racing sensations, can cause increase of your blood pressure. And that increased blood pressure can then damage the endothelial function. So anxiety can drive blood pressure, which can drive atherosclerosis. So in my office, we have a device called the Max Pulse. Any patient that comes in to see me the initial time, we do a 3-minute heart rate variability test, which measures how much stress your body is being exposed to at that moment. You have an autonomic nervous system. Your sympathetic nervous system is that fight or flight response. Parasympathetic is that rest and relaxation branch of the autonomic nervous system. And people who are anxious tend to have high, very sympathetic tone. And they don't have necessarily good stress resilience, so they don't bounce back from it very well. So meditation, deep breathing exercises, exercise, all good things to help potentially with anxiety. But one of my things I enjoy teaching patients is how to use HeartMath, which is a biofeedback device that gives you real-time information about your autonomic nervous system. So check out HeartMath for that. But good question. Thank you for sending it in tonight. So I think we got another one here. So somebody is asking me a question about home EMF, electromagnetic frequency protection. So caveat, not an expert in this. If it's something that's major at your home, you're going to want what's known as a building biologist to come out and use their meters to do the deep dive and figure out what are the sources of the EMFs. But for the do-it-yourself biohacker at home, I usually recommend people get this ENV RD10 monitor. I don't remember exactly where I thought I have where I got it from, but this one does all 3 bands of EMF. So you basically flip it on and then take it to different rooms, and if it lights up red, that's a problem. And so you may have a smart meter in the home, maybe your Wi-Fi router, maybe a cordless telephone, maybe a dryer or refrigerator, the motor on the other side of those things, could be your electrical panel. It's one of those things where it's test don't guess. You got to figure out what is driving those high EMFs and then try to mitigate it. It's the inverse square law. The further you're away from it, the better the fields go down. So if it's a major issue, consider a building biologist. The key place that you really want to look at is in your bedroom, because that's when your mitochondria are repairing themselves at night. So when you sleep, you have apoptosis and autophagy. If you have a lot of EMFs in your fields while you're sleeping, the mitochondria aren't going to work as efficiently, if at all. So I'd recommend, like I said, get a monitor. Do your own testing. I tend to use the ENV RD10 as a quick screen. If you have some fancier monitors, but those are a little bit harder to use for a newbie. Or consider again getting a building biologist. All right. And then somebody had put a couple questions into my comments on my main feed. Somebody asked about are whole foods a key component of a healthy cardiovascular diet? Not necessarily. Some people are gluten sensitive or full-blown celiac. They can't eat those things without having major GI issues, inflammation. So no, it does not have to be, but there's no essential whole wheat that you need in your diet. So base it more off of having a base of your healthy amount of protein to feed your muscles with your metabolic engines. Then it's your carbohydrates based off your exercise load and your current glucose tolerance. If you're really a biohacker, get a continuous glucose monitor and see what type of foods spike your blood sugar. Some people may have really high spikes after eating wheat bread or whole grain products. Now the fiber and the nutrients and vitamins in them are fine, but the wheat may be a problem for some people. No, not essential. All right. And then another question somebody asked, how important is it to drink water for cardiovascular health? So you want to avoid dehydration. A quick check, if you pinch your skin and it sticks up, and you have skin tinting, you're then going to be pretty dehydrated. If you're already having thirst sensation, you're probably already dehydrated. So you want to be drinking throughout the day to avoid those kind of signs, physical signs. A little bit of myth that your urine has to be completely clear. Depends on what vitamins, medications you take and such. But clear urine generally probably going to be better for you. No magic amount exactly, but generally maybe shoot for a ½ ounce per pound of body weight. And it's more important that the water that your cells, the mitochondria, make than it is the water you drink. But if you see me in the office, you always know I talk about trying to at least have your drinking water be fluoride free. Fluoride, irrespective of what it does for your teeth, has an effect on how much energy the water in your mitochondria, how much the energy can be stored in that water, the exclusions on water. So drinking spring water, glacial water, reverse osmosis water, much preferred over general tap water that has fluoride in it. I always get the question, can you strip it out with filters? You can, but it tends to be that those filters are pretty pricey. The ones that are in your fridge or just the pour through filters aren't going to strip out fluoride. And then somebody was asking a more detailed question. I already responded to them, but they were talking about a podcast they listened to that somebody said that they really wanted to see somebody's ApoB levels be in the 60s, and they had listed some of the other labs, normal inflammatory markers, normal HDLC, normal triglycerides. They were like, well, how do you lower ApoB without medications? Do I need to be worried? Again, it's one of those cases, test, don't guess. I can't comment, for an individual, without establishing a patient-physician relationship in my office. But in generalities, you don't know if you should treat an ApoB level unless that person has already had some type of imaging test that tells you that they're at higher risk. So if they've had a CT coronary angiogram, potentially maybe even had a clearly scan, which we're going to be talking about more in the next couple of weeks because I might have some interesting information regarding that scan coming up, which is an AI machine learning algorithm that does a second opinion of the CT angiogram and tells you the plaque characteristics. Or you've had a CT coronary calcium score, or calcium scan for short. That's about the $100 kind of like mammogram for your heart arteries. Great test. I think almost everybody over the age of 40 should probably consider it. If you've had a stent, bypass, heart attack, stroke, you're already high risk. You don't need that test. But that test, while it's good, it's going to miss the earlier stages of plaque when the plaque is soft and potentially more vulnerable. So by the time stuff calcifies, you're still pretty late to the game. So if you have plaque in your arteries, then yes, you probably do want your ApoB particles to be much lower. And there are other options. If you're dead set on not taking prescription medicines, there's different nutraceuticals that can help. If you had excessive high levels to begin with, there's apheresis, which is like dialysis to suck out your apoproteins, but you got to do it a couple times a week. And I personally never referred to anybody for it, but it is an option if you're dead set on taking prescription medications. All right. And then somebody else had thrown a question up. Question is, what causes heart failure with decreased ejection fraction and preserved ejection fraction? So it's an unfortunate name, heart failure. The heart isn't completely broken, but essentially there are two types of heart failure. And the person had mentioned, decreased ejection fraction and preserved ejection fraction. So when the left ventricle fills full of blood, it squeezes or ejects the blood out the aortic valve and sends the blood to your brain and the rest of your body. So normal ejection fractions between 55 and 70%. And the left ventricle doesn't squeeze all the blood out each time that it squeezes. So if you have heart failure and your ejection fraction is normal, then that's considered heart failure preserved EF, or HFpEF for short. Or if your ejection fraction's less than 50%, you know, then you're going to have heart failure, reduced ejection fraction. You know, the heart is a muscle, and muscles have mitochondria. You know, I've seen some data that, you know, your heart is approximately 1/3 mitochondria, and those that have been following me for a while know how important the, you know, circadian biology is, the light water magnetism that we talk about. You know, that has an effect on your mitochondria. So, you know, diastolic heart failure is complicated to treat, not like great treatment options, but think about how do you provide energy to your mitochondria and focus on that. But classic causes of heart failure: hypertension, diabetes, those are the big ones. Iron overload can cause it. There's heavy metal toxicities, you know, mercury can potentially affect it. Ischemia is the other big one as people age. You know, you have blockage in your arteries, starving the tissue of nutrients and oxygen. So those are the main causes of heart failure. So somebody is writing a question in. Thoughts on previous eclamptic seizure 23 years ago on the risk of cardiovascular disease. Their blood pressure is currently low and the heart rate is currently low in the low 50s. So eclamptic seizures are never good. You know, the blood pressure tends to be, you know, pretty significantly elevated, and you start damaging end organs. Typically, you're leaking a lot of protein into the urine because the kidneys are being impacted by that high blood pressure. So there is some idea that, you know, people who have eclampsia have, you know, endothelial dysfunction during that episode. And endothelial dysfunction is, you know, one of the starting blocks for developing atherosclerosis. So people who've had eclampsia in the past are at higher risk of hypertension as well. So again, a test don't guess scenario. So, you know, I'd recommend patients consider getting CT coronary calcium scores as a starting point. You know, do you have calcifications in your arteries? If you have access to a scanning center where you can get a carotid intimal medial thickness test, or CIMT, tells you how old your arteries are. You know, do you have soft plaque in your arteries? Do you have intimal thickening? If your intima is swelling, that means there's ApoB containing particles getting retained in there, and you're starting off to develop more plaque in the arteries. So it is one of those kind of red flags when somebody has a history of eclampsia. So go get your endothelial function checked out. Welcome everybody. So knocking out some questions tonight on the May AMA. Also rocking a new pair of blue blockers that I made myself. It's based off a frame I've had in the past, but was able to find it again on Zenny. Bought the frame, bought some clear lenses. These aren't prescription. Shipped off the lenses to a company that would dip them. So got them dipped with 450 nanometer blocking tint. So these are my day pair for now. I'm going to play around with them a little bit, and maybe in the future, maybe I can start offering some custom Apollo lenses for the people that come see me to the office. All right. So somebody's asking a question about, has saturated fat been dispelled as bad for your heart? Example, butter, bacon, full fat Greek yogurt. So it is, again, one of those ones where it has to be individualized. Saturated fat is neither all good or all bad. ApoE, you know, is a genotype that you can have access to on advanced lab testing. Your ApoE genotype will have an effect on how your body absorbs fats. You know, if you're an ApoE3, might be okay. If you're an ApoE4, might be a problem. So I would, you know, get your ApoE gene checked first. There's also tests where you can look at it's called a cholesterol balance test, where it can tell you, are you a hyperabsorber of sterols? So if you're a hyperabsorber of sterols, eating saturated fats in high quantities, so if you're doing like a full-on carnivore diet, you may hyperabsorb a lot of these fats through the gut. That's going to get repackaged up through the chylomicrons, delivered to the liver, and you're going to make a ton of LDL particles, you know, that have ApoB on the outside of it. And it's the ApoB-containing particles that are, you know, one of the three horsemen leading to atherosclerosis. The other is endothelial dysfunction, the inflammatory response, and those ApoB-containing particles. So, yes, I've seen people who've, you know, been full-on carnivore, done high saturated fat diets, and they've had, you know, ApoBs of like 300. You know, now is that bad for your arteries? I don't know for sure. You have to test your arteries. So if you have endothelial dysfunction and you get imaging tests and says you got plaque in your arteries, probably not the best diet to continue on. In that instance, maybe you should switch up to more monounsaturated fats, so the avocados, the olive oils, or polyunsaturated fats, so the seafood, mostly cold water fish. So again, test don't guess on unsaturated fats. All right, and I think and then somebody had asked a question in my comments before about the artificial sweeteners. So definitely not an expert in these. There was a podcast a few months ago that Dr. Peter Tier did going through them. I believe he kind of personally uses allulose as his kind of go-to if he's going to use things. But the question was, are the artificial sweeteners, basically less bad than regular sugar? But for the most part, they might be. But at least your body knows how to handle regular sugar. Some of the concern with some artificial sweeteners is that while it will not necessarily spike glucose, it does sometimes cause an insulin response. And then your body pumps out insulin and you start pushing down your blood sugar, and then that triggers kind of a hormonal response where your body's like, I need carbs or sugar right now, and then you go eat the regular sugar to raise your blood sugar back up. There's also data that some artificial sweeteners can affect the gut microbiome. And the gut microbiome is extremely complicated, and it's not so easy as just like, let's say probiotics and put good bacteria in there. The gut bacteria use light to communicate, so they're on a circadian clock system as well. But if you damage too much of the quote good bacteria with the artificial sweeteners, then the bad bacteria eat your food first for you. So, I'm just a big proponent of just eating a whole food diet. Eat it the way Mother Nature intended. So, there's carbohydrates built into your fruit, vegetables, go for that. All right. Let's see, I know a few more people have kicked in some questions. I appreciate them. Thank you guys. Hope you guys are having a good Monday. All right. Hey, John, it's been a while. I see you must be down in Florida still, so I think Cassie's going to reach out to you and make sure everything's going well down there. This is what I'm going to do a little research on. You stumped me a little bit. So, new info on recently that there's glial cells in the heart. So, haven't seen the data on that, so I'll have to research that one and come back to you guys on that. So, there's a good question here. So, without a baseline CT coronary calcium score done at age 40, how would you advise a 63-year-old who's getting a calcium score for the first time? So the calcium score test, for those that haven't had done before, it's a very low dose radiation CT scan. It takes maybe 2 minutes for you to do the test. Not a lot of prep. Basically they ask you not to have a bunch of caffeine or eat right before it, just so you don't have a fast heart rate, because they want to take a picture of your heart while it's moving, and the slower your heart rate, the better. But you do not need an IV, and you don't need to take a beta blocker prior to this type of test. Calcium is supposed to be in your bones, in your teeth. It's not supposed to be in the artery walls. Calcium in the artery walls is a marker that there's damage to the artery walls. It's like being in a bad neighborhood and there's bars on the window. So if you have calcium in the arteries, you've had break-ins to the arteries. And that tells you you're still in a bad neighborhood. The blood work can kind of tell you if there's still active break-ins likely. But the calcium score test gives you mostly a risk of what is your risk of having an event in 5 years or so. So the calcium score test can kind of break it down into kind of 4 quadrants. So if you're around 40 years old and your score is 0, that's expected. It doesn't give you too much information at that point. But if you're a 40-year-old and your score is 6, well, that's not the highest score. High score would be anything really over 400. A score of 6 at 40 would be very early to develop that much calcified plaque in the artery. That person, should be aggressively managed. The kind of caveat is, if you're an 80-year-old and your calcium score is 0, then whatever that person's doing is working for them, and don't break them. So the score of 0 kind of gives you more information the older you are. Now in between, if you're 63 years old and your score is 100, that might be about normal for somebody your age, but you may have done more good healthy things over your life, and you may have longevity in your family, and you may have an ApoE2 gene, you might have very robust HDL, reverse cholesterol transport. So you can't tell for sure, what the score of 63-year-olds is going to be, but all comers, your score is probably going to be above 0. The data generally is about 6 out of 10 people who do the score over 40 are going to have a score above 0. So just think of that. If your score is above 0, it means that there's been some break-ins to the arteries. The calcium isn't the problem. It's just that there's a marker that there's also soft plaque in the arteries, and you have 60,000 miles of blood vessels. So atherosclerosis is a systemic disease. This is basically just looking at a very small, few inches of arteries that sit on the outside of the heart. So great starting point test, but there can be more done if your score is 0 or if your score is really high. If your score is really high, well, sometimes you don't need the other test right away. You may need some biomarkers or blood tests to try to figure out, are there other things that are driving that plaque and address it. But anybody who's not had a calcium score test above 60 and they've not already had a heart attack, a stent, a bypass, or a stroke, they should consider that test. But in the future, depending on cost and what is your kind of risk tolerance for medical radiation, which some of these CT coronary angiograms, the millisieverts radiation is really coming down. Definitely down compared to a nuclear stress test or even potentially a coronary angiogram that is invasively looking at the heart arteries. But a CT coronary angiogram will not miss any of the soft plaque in the artery walls. So that might potentially become more of a standard care for people who are more intermediate to high risk. If you're completely low risk, start with the calcium score test. So this is one of my probably, I don't want to say least favorite questions, but it's my N of 1, my experiment. So what does my diet consist of? I'll share it, but it doesn't mean anything necessarily for you because I customize it based off of what my current health goals are. But I do generally eat very seasonally, or at least try to. So Mother Nature uses sunlight to grow plants, photosynthesis. You're supposed to eat them when they're in season, or you eat the animals that eat the plants. I'm very big on timing of meals. I think it's as important, and potentially it's even more important than what you actually fuel the body with. So I generally stay within a 12-hour window, sometimes get into a 10-hour window or less, but I'm not trying to really change body composition, and I already sleep excellently, so I don't really need to affect the timing of my meals anymore. But I'm very consistent about finishing meals at least 3, if not 4 hours before bedtime. So, it's whatever, 6:23 Central Time. I already ate before 6 o'clock tonight, and I'm not going to eat again until probably 7 o'clock tomorrow morning. Then, baseline, always make sure I get my protein. Otherwise, Dr. Lyon's going to tell me I'm doing it wrong. But at least 90 grams a day. But generally, want to shoot for about 1 gram per pound of lean body weight. How do you know what your lean body weight is? Get a DEXA scan or do one of those STIKUs or Fit3Ds, and they tell you how much body fat you have, and then you can figure out approximately how much lean muscle mass you have. Right now I'm doing more kind of a protein smoothie in the morning. It has egg white protein in it, some different berries, different nut butters, almond milk, and blend it up. And then generally I don't snack, pulse in the protein and everything else. Then eat around noontime, and then usually finish around 6. And then right now I'm using a prepackaged service that has all the macros listed out, so I can kind of make it a no-brainer. Don't overcomplicate it. No food emergencies. Just pre-buy it at the beginning of the week and just pull them out. And so, a lot of seafood, chicken, beef, pork, and then whatever seasonal veggies that come with it. All right. Yes, yes. So definitely somebody's asking about, better aimed at where you live. There's also, it gets more nuanced too, what is your ApoE status going to have an effect? What is your cholesterol balance? Are you a hyperabsorber? What are your, mitochondrial haplotype? Are you more kind of sunlight driven, cold driven? So it's more complicated. So that's why I tell people that there's no perfect diet for each person that can say, everybody do this diet. It really depends on where your body is located on this earth. So somebody said that they met a pathologist at a bar. Sounds like a joke. But the pathologist told them that he rarely noticed arterial plaque in alcoholics. Any truth to this? Can't say blanketly, no. The alcoholics got other problems. If they're they're already developing alcoholics, steatohepatitis, they're not going to probably live long enough to get severe atherosclerosis. So, if you live, the data is becoming interesting in that, maybe we should start telling people, you're all going to have atherosclerosis, but you're not all going to die from it. That's the goal, is prevent the events. But now there are some, data for, if you're 20, 30 grams of alcohol in a day, so that's like 1 to 2 drinks, maybe there's some benefit, but the big key is maybe, but it's a curve. You start going higher than that, you're definitely going to get some downside effects. You're going to have high triglycerides, increased inflammation. So I would say it's not a resident alcoholic is immune to having a cardiovascular event. And somebody's saying I need to get on the raw dairy train. I mean, I've tried it before, and I don't have anything necessarily opposed to it, but I'm not a huge dairy person myself. Just don't. Other than cheese, I'll do a ton of cheeses. But. All right. We'll come up to the bottom of the hour, guys. I appreciate your time and attention tonight. These were excellent questions. So for those that don't already know who I am, I'm Dr. Michael Twyman. I focus on heart attack and stroke prevention. I have an office in St. Louis, Missouri, Apollo Cardiology. We have all the latest and greatest non-invasive tests to tell you what is the current state of your arteries. We're very big into looking at endothelial function. How well do your arteries release nitric oxide? We always talk about circadian rhythm management. If you go into our office, all the lights turn off if they're on motion detectors. If you come in my office, it's all glass. I don't have on lamps. And then if you go next door to us in our office, we have the 8-foot beast red light. So if you're interested in trying out photobiomodulation or learning more about it, come see our beast at the office. If you're in St. Louis and ever look at the Euclid building across from the Galleria and it's glowing red, that's going to be our office. So I thank you guys for your attention. Next week, Monday, 6 p.m. Central Time. I talked about last month. I think I'll probably knock it out next week. I was going to talk about kind of the difference in cardiovascular risk in men and women. I've had somebody ask me about menopause and estrogen having an effect on cardiovascular health, so I'll go over that next week. So see you guys next week. If you have anything that you need in the interim, just send me a message. So take care.